Hello, I'm Ami Banerjee. I'm Professor of Clinical Data Science and a consultant cardiologist and leading the Stimulate ICP study. I'm going to hand over to Lyth Ishmay.
Hello, everyone. I'm Lyth Ishmay. I'm a patient advocate. I have lived experience of long COVID, and I'm a patient representative on Stimulate ICP trial.
Thank you, Lyth. And last but not least, to Melissa Heitman.
Hello, I'm Mel Heitman. I am a consultant respiratory physician and I lead a post-COVID service in London, and I'm working with Ami and Lyth on the Stimulate ICP study.
Thank you both. So this Stimulate ICP study involves a trial and various observational studies, and we thought it would give us the opportunity to discuss some of the core principles of evidence-based medicine. And in long COVID, which is a new disease where we're defining the outcomes, defining the treatments, defining the right study designs, it's important to revisit these underpinning principles. So evidence-based medicine was formulated and founded in the 1990s in McMaster University by Professor David Sackett. And from the outset, it was about underpinning what we do in clinical practice with the best quality evidence. But from the outset, it had clinician expertise involved in it, and it had patient values involved in it as well. So it wasn't just about science in a different silo from us practicing healthcare, which people have sometimes interpreted to be kind of depersonalizing healthcare. So what we're trying to do in Stimulate ICP is to look at the evidence for certain treatments, for investigations, for rehabilitation, using those principles so that we can try and, as quickly as possible, apply that knowledge in clinical practice for the benefit of patients. Lyth, do you want to say what your experience or what your understanding has been of evidence-based medicine in this space?
So, in a nutshell, my view on evidence-based medicine is it's making clinical decisions based on scientific evidence. Now, can you tell me what form that scientific evidence usually takes? And is there a threshold or a criteria that it has to, let's say, fit for it to be considered evidence?
Great question. So people talk about a pyramid of evidence, and they've traditionally seen randomized control trials as the best form of evidence to inform clinical practice. And ideally, you'd have several studies or several trials where you can, if you like, pool the data from those trials and do what's called a meta-analysis and a systematic review to get the overall findings of the body of evidence. But there are other types of evidence, such as trials where you're not randomizing people, where you're not having control patients. There are studies where you're taking a group of patients, or what's called a cohort of people with, in this case, long COVID, and following them up and seeing what happens and maybe giving them treatments. And the lowest part of the pyramid, and particularly when you have new diseases, this happens, and it's happened with all new diseases historically, is case studies and then case series. So you end up with, first of all, single patients and then groups of patients who people have seen in services. And so we've had all of those kind of types of evidence in the long COVID space. So you asked about a threshold. Yes. And that's a good point. In treatments, the threshold is determined by the health system you're operating in. And in the UK, we have a body called NICE, the National Institute for Clinical Excellence. And that, in a peer-reviewed manner, looks at the evidence for effectiveness, whether something works, and cost effectiveness, whether the cost outweighs the benefit at society level. And they decide whether we should be rolling out particular treatments. So that's the threshold that there is in our setting.
Right. So earlier on, when I had long COVID in 2020, I remember contacting my GP multiple times and complaining of brain fog, palpitations, all these things. And the one thing that repeatedly said to me that I will never forget was, there's no evidence that COVID causes that. You must be anxious. Now, I'm thinking, does evidence-based medicine work when we're dealing with such a novel virus or even any new disease? And I mean, we know that clinicians train for years to be able to work empirically. Back in the old days, hundreds of years ago, we didn't have any evidence, and they just, they worked with what they could. Can you comment on that?
So I think in an ideal world, we do want to practice with the best scientific evidence, but we end up always, even where there is evidence, practicing with that evidence, but armed with expertise, so being trained in whatever it is that we have expertise. So Mel, for example, is a respiratory consultant, but she's a specialist in long COVID as a clinician, but also it's experience. So that expertise and experience combined with the evidence is useful, because it's relatively rare to have a trial or a study which directly applies to the patient, the person sitting in front of me in clinic or in the hospital. So you're always having to practice as a health professional with that uncertainty. Is there something wrong with doing evidence-based medicine, and is that kind of what's holding us up? I think I would argue the opposite, potentially, that where we have a new disease and at the scale that we have in long COVID, we need to make sure we're gathering data and doing research as we're rolling out services, because we want to make sure that, first of all, we're doing no harm with what we're doing, and secondly, to see if we can do good, and if there are things that we're doing, drugs that we're using, rehabilitation strategies that we're using that are helpful, that we roll them out at scale and pull back the things that are not so helpful or neutral or harmful. So that's why we do need evidence. And when people say we don't have the evidence to do it, I think maybe that's actually using principles of good medical practice, where, if you go back to kind of Hippocratic Oath type stuff, it's do no harm. But we're also, as doctors, governed by the General Medical Council, and also, if you're a nurse or allied health professional, it might be the Nursing and Midwifery Council, where your professional practice involves you using the best possible evidence as well. So you kind of have to have really good reasons to go off-piste. I don't know if, Mel, do you want to add to that at all?
Yeah, I think, Lyde, as you say, we've had to, with long COVID, draw an MDT team into case discussion of patients to bring the best expertise for all the different symptoms that patients experience. But recently there's been some preliminary data suggesting that certain treatments might be helpful in long COVID. And I wondered, Ami, what you thought the clinician response to those small studies should be, whether we should still return to evidence-based medicine principles, or, given the urgency of the situation, whether we should be more pragmatic and try out these proposed pharmacotherapies, for example.
I would say that it's a really unique and unfortunate situation where we do have such a lot that we don't know about the condition, and we have so many people who, because of high infection rates and because of the nature of COVID, have long COVID now. And so I understand why there's a push, whether it's health professionals, researchers, or patients themselves, to go ahead and do stuff and use treatments. But even if we do that, we should gather information, gather data, and make sure we're doing it as research, because otherwise we know from various historical events in medical care that we might be doing harm. We might be actually showing a placebo effect, particularly where drugs and treatments can be charged for, there's a conflict of interest. And so if I am selling you something, then I'm unlikely to tell you that it doesn't work. And that in itself is not evidence that it works just because you can pay for it and it works. I might still be doing harm. So I would say it's particularly in a healthcare system like ours, where we have to try and do what we can at population level to the best of our ability. We should, if we're going to try new treatments, we should do it in a trial or gathering observational data going forward, so that we can provide data to show what works quickly and then roll it out.
The problem is with this approach is that trials usually want evidence to show that certain treatments work, and certain treatments need evidence to be trialed. So we end up in a chicken and egg problem where you can neither do this nor that. And I understand how with established illnesses this might not be a problem because there's evidence going back hundreds of years ago, for instance. But when we don't have that evidence, for instance, when they discovered the vaccine for smallpox, I understand it was completely by fluke. In that situation, long COVID patients can't just sit there and wait because the evidence just isn't. It's not forthcoming, and people are just will be more inclined to try things that don't work and that could be harming them. They'd be more inclined to seek treatments from people who, like you said, normally don't have their best interests at heart. So can you argue in this specific situation that it might be better to try to act without having the most solid evidence base, let's say?
Well, I think that's already been happening because of the clinical need and the sheer numbers of people presenting to clinicians like Mel. And so people are trying different treatments out. And actually, that's what's fueled the trial in the case of Stimulate ICP. There's preliminary data. So in a small number of patients, or in some patients, you try out antihistamines or rivaroxaban, the anti-clotting agent, and see if there's improvement. And that was preliminary data that convinced, whether it's our funder, NIHR, or the MHRA, the medicines regulator, that it's safe to try and do a larger trial of it. And if we didn't have that, and we just went straight to the big trial and just gave it to everybody, that's actually against what we over decades have found across diseases and across healthcare, where you need to go, if you're making new compounds, you go from animal studies or in vitro studies and first in human studies and so on, until you get to a trial which is definitive. Here in Stimulate ICP, we're looking at medicines that have been used for other conditions and seeing if we can move sideways and repurpose them to the long COVID situation. But still, the regulator wants to know, is there any chance of harm? Are you going to be measuring it? If there is an effect, are you measuring it properly? So all of those hoops are actually there to protect patients and patient safety. It feels like red tape, but actually it's there to make sure that we don't commit a population scale boo-boo here. So I think there is a balance to be had for sure, but even if we're going to try things out, which has been happening, that's actually helped the research and pushed it along. Not quickly enough, we might argue, but that's how we are moving towards trials. And there's lots of different groups who are doing not trial work, but mechanistic work, looking at immunology, or, for example, Regia Pretorius's group looking at clotting mechanisms and microclots, or other groups like colleagues at UCL who are looking at antihistamines and whether they work. They're doing work to try and underpin further trials. So it's to see the whole totality of the science. No one study can always give the definitive answer.
Thank you, Ami.
So I think where we've got to is that, you know, maybe the application is sometimes not perfect, but the principle of evidence-based medicine is still about doing the best for patients and trying to do it with clinician expertise, but the best scientific evidence. And where we have none, we have to try and move towards a situation where we can get some evidence. And that ideally is in the form of trials, but it might not be. So in a series of short sessions, we're going to be talking about trials, diagnostics, and other aspects of evidence-based medicine, and hopefully try and shed some light on what's happening in this space in long COVID. Thank you.